good evening, sir.
Sir, good evening, sir.
Good evening, sir. Sir, we'll start in a minute. Professor Mote has joined already.
Good evening, sir. Mote, sir, good evening.
Kanna, sir, good evening, sir.
Sir is not there, sir, I think.
No, he's just joined. He very promptly joined, sir. Good evening, sir. Kanna, sir.
Sir, good evening, sir. Khanna, sir, good evening.
Good evening. Good evening.
Good evening, sir. Warm welcome to you, friends. We warmly welcome you for the yet another postgraduate clinics this evening. We have two important exam cases. One is a case of a splenic mass to be presented by Dr. Abhishek from KM. The other one is a lump from the breast, and it's going to be presented by Dr. Madhu from AIMS Bhopal. And we have three eminent invited faculty. Professor DJ Mote, sir, he is a new faculty for our program. Warmly welcome, sir. He is a professor of surgery at Bharati Vidyapeeth, Sangli. And sir is an eminent teacher, and he's been teaching postgraduate students for the past 2 decades. And we warmly welcome you, sir, for the postgraduate class.
Thank you, sir. Thank you.
And, thank you for joining us this evening. And he's been kindly introduced by Professor Nishikant, sir. Thank you, Professor Nishikant, sir, for introducing Professor Mote. And we expect Dr. Mayank and Mayank from Tata Memorial Center at Varanasi, and we expect Madam Swagata from AIMS Bhopal shortly. And we have our own faculty, Dr. Khanna sir from Varanasi, Dr. Rajiv Sakai sir from Delhi, and we have Nishi sir from Vijaypura. And without much ado, we'll start the session. We'll have the honor of having Dr. Abhishek to present the first case. Dr. Abhishek, please introduce yourself. You are head of the unit, head of the department, and start your presentation. Good luck to you.
Thank you, sir.
What I said, normally these boys present till the history end without halting. And then we revisit slide by slide, and you can give your questions and comments. Same way, clinical examination, they present without halting. And then at the end, once they come to the diagnosis, the initial part, they also have imaging and some reports which are associated with that. Then we can take you through the management side. So good luck to you, Dr. Abhishek. Please start your PowerPoint and start your presentation.
Okay.
Faculty, please take over.
Yes.
Thank you, sir. Am I audible, sir?
Perfect, ma. Perfect. Good luck to you.
Good evening, everyone. I'm Dr. Abhishek Kurkote.
We are yet to see your slides.
Is it visible, sir?
Yes.
Yeah, perfect. Good luck to you.
Yes, sir. So good evening, everyone. I am Dr. Abhishek Kurkote. I am a third-year resident at General Surgery Department in KM Hospital, Mumbai. My head of unit is Dr. Shilpa Rao, ma'am, and the HOD of the unit is Dr. Varsha Kulkarni, ma'am. So I'll be beginning with my presentation. A 45-year-old lady, resident of Thane, a homemaker, presented to our OPD with complaints of abdominal lump since 6 months. Patient was asymptomatic 6 months ago when she observed a lump in the abdomen in the left upper quadrant. Lump was associated with pain, which was felt in the left upper quadrant. It was insidious in onset, dull aching type, non-progressive nature, and was very intermittent. There was no any aggravating factor and has no radiation. Patient was relieved by some oral analgesics medication, which was prescribed by the local doctor. The patient had visited a local doctor for the similar complaints 6 months ago. She had a lump in abdomen, she had chronic cough, and she had fever 6 months ago, for which she had visited a local doctor and was investigated with a USG and further a CT scan as well. Patient was informed that that there was a swelling in her spleen and was referred to KM Hospital for further management. Patient gives no history of any fever, chills, rigor, no history of any nausea, vomiting, altered bowel habits. There is no history of any jaundice, hematemesis, melena, bleeding PR, generalized body swelling, anorexia, weight loss, or any history of trauma. Patient has no history of similar complaints whatsoever in the past. No history of any chronic illnesses. No history of any surgery. No history of any blood transfusions, and no history of any allergies as well. Patient consumes mixed diet. There is no history of any alcohol consumption. Patient has normal sleep cycles. Patient has para 2, life 2, menstruating with regular cycles currently, and no significant family history. I would like to summarize. She's a 45-year-old lady coming with complaints of lump in upper left quadrant with no comorbidities. My differentials would be splenomegaly and a splenic flexure mass.
Let's go to your first slide, please.
Yes, sir.
So this lady's come with just an abdominal lump for 6 months.
Currently to our OPD, yes, sir. It's only these symptoms, no other symptoms.
So what were the symptoms before 6 months?
Before 6 months, she had a chronic cough for a month and intermittent fever, for which she had actually went to a local.
So I think you will have to mention that also.
Okay, sir.
Right?
Yes.
You have to mention whatever the complaints are. It could be she's come now to you with this, but then if you see she's had this before also. So
Okay,
she's
sir.
had this fever and cough
Yes,
for
sir.
how many days?
For 1 month, for which she was managing conservatively at her home. After which,
So 6 months ago she had this problem.
yes, sir.
Then she saw some surgeon, some doctor,
Yes, sir.
and she was referred to KEM.
No, she was initially investigated by that doctor.
Mhm.
Felt a lump in abdomen, which that is mentioned in his history, and a USG and
So
some.
now this pain is gone.
Sorry, sir. Now the pain has gone. Yes, sir. Now there's no pain.
No pain at all.
Pain at all.
Okay, so what do you think was this all about? That she had a lump, and they had this. They said there's some splenic cyst with fever. What do you think could have been?
Sir.
Is there any history of trauma?
No, sir. No history of trauma.
Have you taken that history?
Yes, sir. I have. I have ruled that out.
Okay.
Yes,
So
sir.
what else what could it be?
Sir, giving the complaints, I would initially think of some infective etiology.
Right.
Yes, sir.
So what infective etiology with the enlarged spleen? With fever and cough.
Mostly malaria is one of the history. Kala Azar I won't choose
No,
because
no. Malaria with malaria. Okay, yeah, that's fine. But malaria won't go on for such a long time, no?
yes, sir. Yes, sir.
1
There
month.
will be rapid fever spikes. Yes, sir. Mostly some parasitic infection is what I'd suggest.
No, can you think of a splenic abscess?
There was no history of any high grade fever but yes, sir, I would think of it, sir.
So what kind of fever was this?
It was mild fever, which was intermittent, sir. It was not like very high grade fever at all.
No, so she had gone to the first doctor for what complaint? For pain or for fever?
Chronic cough. Chronic cough was her initial complaints that she had, and she was not getting treated. Chronic cough was associated with fever intermittently for a couple of days. That's it. There was no.
Okay, so just a couple of days of fever.
Yes, sir.
And cough.
Yes, sir. Chronic cough she had.
So can it this just be an incidental finding?
Yes, sir. It could have. It is an incidental finding, sir.
It's incidental. Okay, next slide, please. Okay, next slide. Now, what are the structures which you'll rule out, which can give you pain in this side, on the left upper quadrant?
Sir, pain, the organs that I would think of would be the spleen, the tail of pancreas or stomach, or the splenic flexure of colon. So these were this was which I was thinking, but like.
So what is characteristic of a pancreatic pathology in this case? If there's a pain and then it subsides and there's a lump left behind.
I would think of a pseudocyst of pancreas initially.
So how long would it take a pseudocyst to form?
Around 6 weeks, sir.
So she's 6 weeks now. She is.
She has passed 6 weeks.
So why have you in your differentials just kept the spleen? What have you kept in your differentials? Splenic cyst or something like that.
Yes, sir.
Why? By your history, why have you kept that?
Sir, because pancreas, if she would have had an initial attack of pancreatitis, then there would have been fever. Not fever, but there would have been extreme pain, or she must have had some admission.
Necessary. Look, Abhishek,
Yes,
what
sir.
I'm trying to say is that by your history, we can't come to a diagnosis of, or even of a differential of a splenic cyst or a hepatic flexure, a
Right,
splenic flexure, because she's got no symptoms of the bowel.
right, sir.
She's
No,
got,
bowel. Yes, sir.
right?
No,
A pancreatic swelling can present like that.
right, sir.
Had fever and all, had pain. Now there's just a lump.
Right.
Abhishek, if you are thinking about pancreatitis, what typical pain of pancreatitis will be there?
Sorry, sir.
Pain of acute pancreatitis, how you describe? Typical pain of pancreatitis. If there is history of pancreatitis,
Sir, it's a sharp pain in
Characteristic.
the epigastric region, which is radiating to the back, and patient would be in leaning forward position, which he gives history on leaning forward. There's relief. The patient feels relieved from pain, sir.
okay. So such pain was, such history was there.
No, sir. There's no history of any acute pain that she had. She just had intermittent pain, which was dull aching in nature. No radiation, and it was also relieved with some analgesics that was given by the local doctor.
So it was just a dull aching pain.
Yes, sir.
Okay. So any other
Abhishek.
possibility? Any other possibility you are thinking?
Yes, sir. I would still keep pseudocyst of pancreas, as sir mentioned. I would like to keep pseudocyst of pancreas as
You
one
want
of
to keep
the.
that. Okay.
Yes, sir.
Abhishek,
Yes, sir.
in this case, there is a mass lump in a left upper quadrant of the abdomen. So
Yes.
which negative history is supposed to exclude in this patient?
Which negative history, sir?
Because which negative history we supposed to ask the patient?
Sir.
Because there is no marks for your correct diagnosis. There is marks for your way how you are excluding other possibilities, differential diagnosis.
Yes, sir.
Abhishek, sorry.
Yes,
Most
sir.
patients of cirrhosis, they don't present with acute features of acute pancreatitis.
Okay.
Yes.
They present with a history of a fall or maybe a trivial trauma.
Right, sir.
Right. So don't go. Yeah, go on, please.
Abhishek,
Yes, sir.
which history we supposed to exclude considering it as a left-sided, left upper quadrant mass?
Sir, left-sided upper quadrant mass, splenomegaly could be there, which
Okay. So how will you exclude the history regarding splenomegaly?
most commonly portal hypertension I would try to rule out for this patient.
So how will you rule out portal hypertension? Which questions we supposed to ask the patient?
Any history of hematemesis or melena, which will rule out the variceal history.
Okay, good.
There's no any
Good.
history of alcohol that I have taken in the personal history, or
Okay, good.
there's no history of any jaundice, which like there's no any history of cirrhosis. That means or any generalized body swelling, or the chronic classic features of chronic liver disease, sir.
Okay. Any other pathology other than spleen?
Are there any infective, like as sir mentioned, abscess? I ruled out by fever, chills, and rigor, which again rules out malaria or any other infection for that matter. According to the age, CS stomach is not so common at 45 years of age, but some gastric lump or mass can also present, and hence nausea, vomiting, and history was taken for that patient.
Other than spleen?
Sir, colon left the.
Very good. Colonic pathology.
Yes, sir.
Left-sided colonic pathology. So which history we supposed to ask?
Sir, altered bowel habits can be.
Altered bowel habit.
Yes, sir.
Okay.
Tenesmus also patient might present if there's lump or
Tenesmus.
yes, sir.
Tenesmus
no.
is for the
Colonic.
rectal growth, not for the colonic growth.
Okay, sir. Sorry,
We are
sir.
discussing about the splenic flexure of colon.
Yes, sir. Okay, sir. Sorry, sir.
Hmm.
There could be anemia that patient might have because of lower GI bleed if there's any mass in the splenic flexure of colon, sir. Which patient will present with any dyspnea or fatigue that he on doing normal daily activities. And
What about a renal?
sorry, sir.
What about a renal lump? Hydronephrosis.
Yes.
Yes. This is also one of the important point.
When you are thinking about splenic lump, you have to always think about differential diagnosis of a renal lump also, left side,
Right, sir.
because that is most common question usually asked.
So Abhishek, what have you got in hand? You've got a patient, a 45-year patient with history of pain and fever, now presenting with a lump in the left upper quadrant, probably some splenic collection,
Right, sir.
right?
Right, sir.
So now try to associate what can be the conditions which lead to this. Or
So-
let's forget your previous ultrasound or CT scan.
Yes, sir.
What do you think you're dealing with? Most
Sir-
likely.
Could be
Look, splenic pathology is very difficult to get a history out of.
right, sir.
Right? You can't come out with a history of a splenic pathology. They're all
Yes.
very vague.
Yes, sir.
Right? So by history, we'll have to think of something more contingent.
Okay, sir.
See,
Some dealing with the history, it looks like
why
something.
don't you think about any other tumors there arising from other structures?
Hepatic.
It may be retroperitoneal also.
Yes, sir. Adrenal.
At this stage, why you are just talking about spleen?
Yes, sir. Adrenal malignancy can also be present.
Renal, any other retroperitoneal malignancy, any tumor, just a vague pain is there.
Right, sir. Could be, sir. Retroperitoneal.
Some history of fever. There are no GI symptoms, no other symptoms, no urinary symptoms.
Yes, sir. I'd like to add that to my differential as well,
Right.
sir.
So you're different because your patient has got very vague symptoms.
Yes,
You're
sir.
not going to put a finger onto any one organ.
Right,
So
sir.
include the most likely stuff there, right?
Okay, sir.
You can go for a splenic cyst or a splenic abscess, or you can go for a pseudocyst. You can have a pseudocyst within spleen also.
Spleen also, yes.
Right?
Yes, sir.
You can go in for hydronephrosis, you can go for retroperitoneal, you can go for a cyst of the stomach which is not invaded the mucosa.
Right, sir.
Right? They are all differentials.
Okay, sir.
Yeah, so although rare, but sometimes gastric cyst also can present like that, right?
Right, sir.
Should we go to the examination, sir? Yeah, we should go to the examination.
Okay, sir. So patient was examined in a well-lit room after proper consent was taken and in presence of a female chaperone. Patient was lying in supine position, adequately exposed, and all procedures were explained. Patient is averagely built with adequate nutrition. BMI is 19.8 for the patient. Vitals, the patient was afebrile. Pulse was around 78 beats per minute, regular and normovolumic. BP was 128 by 80 millimeters of mercury in the right arm in a supine position. Respiratory rate was 18 cycles per minute, abdominal thoracic. There was no any pallor, icterus, cyanosis, clubbing, generalized edema, or lymphadenopathy that was there in patient. Local examination on inspection, the skin over the abdomen appeared normal. There was no any evidence of any scars, sinuses, or dilated veins. There was no any lump that was visible on inspection. There was no visible peristalsis or pulsations that were visible. All quadrants moved equally with respiration, and both the inguinal regions appeared normal. On palpation, the signs of inspections were confirmed. The abdomen, the temperature was normal. There was no any tenderness. On palpation, the spleen was palpable between the umbilicus and the costal margin, which was non-tender. The surface was smooth, firm in consistency, and a palpable notch was there along its edge. Fingers could not be insinuated above the swelling. It measured around 4 centimeters from the left costal margin. On percussion, the lump that was produced had a dull note, and there was no any evidence of free fluid in the abdomen. On auscultation, normal bowel sounds were heard. A digital rectal examination and proctoscopic examination was also done, which showed no any abnormal findings. Lymph nodes were also palpable. Lymph nodes were also palpated, but there was no any lymph node palpable. Systemic examination, the cardiovascular, the CNS, and the respiratory system was no any abnormality was found. Right. Sir.
Okay, let's go back to your examination. That's fine. Next one. Okay, no. Okay, next. Signs of inspection confirmed. What do you mean by that? I've never heard of this. Signs of inspection.
As mean, my findings of inspections were confirmed as in the
What were your findings in your inspection which you confirmed?
as the
Was there any positive finding in your inspection?
No, sir. I should not write that line, sir. Sorry.
Just go back to your inspection.
Don't mention such terminologies.
Yes, sir.
Huh?
Okay, sir.
So skin appears normal, dilated veins. Okay, there's no visible lump. Okay, next slide, please. So you just got a spleen. Next slide. Okay. Have you inspected the renal angle?
Yes, I did. There was.
But you've not mentioned it there.
Yes.
Look, by your inspection and by your clinical examination,
Right, sir.
we have to rule out things like spleen, kidney,
Yes, sir.
stomach,
Right.
right? So how do you rule out each of these organs? What is the characteristic of a renal mass on inspection?
On inspection.
I'll add to this. What is the difference between renal swelling and splenic swelling? How the difference is between these two?
Sir, both on inspection, sir, first of all, splenic swelling and renal swelling. The splenic swelling, the fingers could be insinuated. We won't be able to insinuate if it's a splenic swelling. If it's a renal lump, then it would be possible.
That is one. Next.
Direction, the growth of direction of splenic swelling is towards the right iliac fossa, whereas that lump will be palpated just towards the left quadrant of the patient.
Why this difference is there? What is the reason for this?
Sir, because of the ligaments around the spleen, the gastrocolic and the splenocholic and the splenophrenic ligament,
Which is the one ligament?
the phrenicocholic,
ligament which prevents.
the phrenicocholic, sir.
Okay. Next, other differences.
Renal lump will be balutable. That the swelling is balutable, sir.
Next. This is very regular, easy to see. What are other characteristics, differentiating points between splenic and renal, left side? Hello.
Yes, sir. Yes, sir.
Hmm.
Sir, the splenic notch will be palpated.
Yes, it's very good. Next.
No, any upper border of the splenic swelling could be won't be palpable, whereas in renal lump, the upper border might be palpable.
Yes. Any other on palpation, any other percussion, any other differences there? On percussion.
Sir, since renal like kidneys are retroperitoneal, that instead of dull note, the bowel the tympanic note of the bowel might be would be heard on
Always. Always.
not always, but like the splenic will be always dull, but the renal swelling might not be always dull.
Okay.
Abhishek, what is band of colonic resonance? That is one of the difference between the splenic and the renal lump. Normally, when you percuss the renal angles, is it dull or resonant on percussion?
Renal angle dull, sir.
Normally,
Normally, it will be resonant, but normally it will be resonant, sir,
so why it is resonant?
because of the bowel, sir. I mean, the overlying bowel that is present.
Which overlying bowel?
The colon, the descending colon part.
Ascending and the descending colon, right? On the right side, ascending
Yes,
colon, on the left
ascending
side,
and
descending.
yes, sir, ascending and the descending colon.
Now tell about what is the band of colonic resonance. Now you can probably tell that.
Sir, the colon
Angle is
that's
normally
ascending and
resonant on percussion.
that the part where the colon is overlying the renal part, that will be resonant. That will be the band of colonic resonance, sir.
So when there is enlargement of the kidney is there,
Right.
it displaces the colon anteriorly.
Right, sir.
Okay, so anteriorly you can find that there is a band which is resonant in between the dull areas here.
Right, sir.
But this is present in how many % of cases of the renal lumps? It's only in about 10% cases. Only in about 10% cases you will get the band of colonic resonance. Okay, so that is also one of the difference between the splenic lump and the renal lump.
Abhishek,
Yes, sir.
Have you checked for the ballotability of the bimanual palpable lump in
Yes.
your? So what is your lump? Is it ballotable or bimanual palpable?
It's not ballotable, sir.
What is the difference between these two, ballotability and the bimanual palpation?
Ballotability, sir, you can between two, like if you press it around the finger, two hands, like two palms, when you push it from one side, it will be it will be felt on the other side. That is ballotability, sir.
Okay. And bimanual palpation? What is bimanual palpation? You keep the hand both anterior and the posterior, and you can feel the lump in between these two.
Yes.
You do not need to push the lump. to be felt by the other hand.
Right, sir.
So are the renal angles barotable or they are biminally palpable?
Renal angle would be ballotable, sir.
Small renal lumps will be barotable,
Small will be.
but the
and
large renal lump will be biminally
biminally palpable, sir.
So it can be both. No, if it is small renal lump is there, it will be barotable. If it is a large one is there, it is biminally palpable.
Right, sir.
Okay.
Abhishek,
Yes, sir.
Abhishek,
Yes, sir.
Abhishek,
Yes, sir.
am I audible?
Yes, sir. I can hear you, sir.
Abhishek, according to me, your examination, order of examination is not complete. Inspection and palpation order of examination is not complete. So which points are missing in this? Considering a lump in abdomen, which points are missing?
Mm.
Now in CBME, we are keeping clinical examination sessions and we are providing the order of examination also. And previously also in our time,
Okay.
teachers used to assess this order of examination. You have not mentioned about spine and left supraclavicular area. Forget about any case, forget about any pathology, you have to mention the renal angle, spine, left supraclavicular fossa and external genital. Unless and until it is not there, your examination is not complete.
Right, sir.
Hmm?
Right, sir.
There is no doubt.
Okay, what are various methods to palpate the spleen, Abhishek?
So in the first method, you keep your hand in the right iliac fossa. It will be and you move towards the
So you are telling me what is cardinal rule of palpation?
yes, sir.
How one should start the palpation properly?
By standing on the right side of the patient with knees and hips flexed. Start the palpation from the right iliac fossa towards the left costal margin.
What is the rule? You should always start from right iliac fossa. It may be convenient, but what is the
You
rule?
can start from the left as well, sir, and move.
So when we start from left, when we start from right, what is there? Any rule is there or any? Why we start from for left hypochondrium? We start from the right iliac fossa. What is this relation?
So because the spleen grows towards the growth of
Usually we start from diagonally opposite quadrant.
yes, sir.
Then we go to the pathological side.
Hmm.
So what are various methods of palpation of spleen? Why we should have those different methods? Because your case is related to splenic swelling.
Yes, sir. One method is where we move parallel to the costal margin from the right iliac fossa towards the left costal margin.
Okay.
What is the name of this method? These are basic questions, Abhishek. Classical method.
Yes, sir. Classical.
Okay. One is the classical. Second,
one is the dip method also, sir.
dipping method.
Yes, sir.
In case of ascites. Then
Yes.
third, hooking.
Yes, sir. Okay.
Fourth, bimanual palpation.
These four methods are there.
Right, sir.
So when you should go to the opposite side to palpate the spleen? Already told.
Sir, as it grows towards
How many times spleen should grow or enlarge in size to be palpable?
Around three times, 3 to 4 times the normal size, sir.
Okay. What else you have examined?
Sorry, sir.
What else you have examined?
I have examined all the quadrants of the abdomen. Liver was not palpable. The inguinal regions were also assessed but there was no any finding in the inguinal region. The patient was examined for other lymph nodes like the supraclavicular and the axillary lymph nodes, which was not palpable. Digital rectal examination and a proctoscopic examination was also done, which was also there's no any significant findings that were.
Why we should examine left supraclavicular fossa lymph nodes?
Sir, the Werkow's nodes, since the mass is in the lump is in the uh, left upper quadrant, there are chances of metastasis. If it would have been a malignancy, then chances of metastasis to the Werkow's nodes are possible, sir.
What are those malignancies?
Sir, gastric CA is one of the important.
Then any other?
Abhishek,
Yes, sir.
what is left-sided portal hypertension?
Um, Splenic when this splenic vein thrombosis or
Okay, this is called as
left-sided portal hypertension.
you have mentioned that there is no ascites.
Yes, sir.
What is mechanism of ascites in the patient with liver cirrhosis or in portal hypertension?
Sir, in liver cirrhosis, the oncotic pressure would be low, and hence the hydrostatic pressure would. Hello.
First is there is a formation of the hepatic and splanchnic lymph. Increased formation of the hepatic and splanchnic lymph, hypoalbuminemia, and retention of the salt and water. These are the basic theories for the ascites.
Yes, sir.
You have to keep it in the mind.
Just going to the previous question, how this abdominal malignancy spreads to left supraclavicular lymph nodes? What is the path of spread? How this tumor cells gets there?
Sir, so via the lymphatic channels through the thoracic duct, it goes towards the.
So what are those channels? How they go there?
Sir, via the thoracic.
It may be stomach, it may be colon, it may be pancreas, even it may be testes also.
Yes, sir.
It goes there. What is that path? What is that sign called? Other name for
the Trozier sign, sir.
Trozier sign. Okay. Okay, you were talking about ascites. How
Yes.
to rule out ascites, minimal ascites? What are various clinical methods to detect free fluid in the abdomen? Now, what is the normal amount of fluid you get in the abdomen?
Sir,
Normally.
normally around
Normally,
less
normal
than
subject will also have some fluid in the peritoneal
less
cavity.
than 50 ml, less 50 ml.
Okay.
So,
Abhishek, these are commonly asked NEET questions. What is
so
normal amount of intra-abdominal fluid? How much fluid is required to detect the minimal ascites? How much fluid is required to shifting dullness and harsher dullness? These are the commonly asked questions for your NEET exam.
Yes, sir.
Suppose this is the case of the portal hypertension with cirrhosis. Tell me how cirrhosis causes portal hypertension in patient with a chronic alcoholism. What is basic pathology?
Um,
Just think. You are knowing this answer. It's not difficult question. Just think on it. And don't get disturbed.
for the sinusoidal pressure will increase, sir, which will
What
manifest.
alcohol causes? Alcohol causes the liver cell damage. It leads to the fibrosis and nodule formation.
Yes, sir, and hence the sinusoidal pressure.
And this fibrosis after the portal venous pressure, portal venous return, and it will cause the portal hypertension. Okay, proceed.
Abhishek,
Yes, sir.
coming back to the supraclavicular node, which is there, you know where it is situated?
Sorry, sir,
What
where
is the location of this Wernicke's node?
the left supraclavicular area is where it is.
Where in the left supraclavicular area? It is in between the two heads of the sternocleidomastoid. Okay, so that is classically Wernicke's node, that which is in between the two heads of the sternocleidomastoid. You know what is Wernicke's triad? Have you heard about that?
Yes, sir. Sir, hypercoagulability, endothelial damage, and stasis is the workhouse triad.
What it leads to? What it leads to? What is the condition caused by that?
Thrombosis for cause formation of thrombus formation.
Which thrombosis? Deep vein thrombosis, you know? It leads to the deep vein thrombosis.
Yes.
And what is Wernicke's method? Any idea? The Wernicke's node is there, Wernicke's triad is there, and Wernicke's method is there. Any idea about that? Wernicke's method?
No.
Wernicke's method is during the postmortem, when you remove one organ by one organ. So that's serial order. That is called the Wernicke's model method.
Yes, sir.
Okay, go ahead. Yeah. What is left-sided hypertension known as? Portal hypertension known as?
Sir, sinister
Sinister hypertension. So go to your diagnosis now.
Sir, in patient had presented with these investigations done already to.
Leave the investigation behind.
Okay.
Let us discuss the clinical diagnosis first. So what was your order of clinical diagnosis? After you have done the history and the examination.
Patient, 45-year-old lady with mild splenomegaly with no comorbidity.
I'm not asking the history now. Okay, I'm asking with the diagnosis. What is your working diagnosis and what is your differential diagnosis?
Patient has splenomegaly currently. So and I would like to further investigate it. But currently, splenomegaly and or a splenic cyst or a pancreatic pseudocyst is what I am suspecting right now, sir.
Is it moving with respiration or not?
Sorry, sir.
Excuse me.
Does this lump move with respiration or not?
Pancreatic
Yes,
cyst.
sir, it does move with respiration.
So do you think the pseudopancreatic cyst will move with respiration?
No, sir. It won't.
Hmm?
No, sir.
So you can exclude only by single test there,
Right, sir.
right? Does the gist of the stomach move with respiration or not?
Mm. No, sir.
No, it will move.
Okay.
Okay, if it is arising from the fundus of the stomach is there.
Right, so if it's
Huh?
attached, yes, sir.
So that may be your second diagnosis here as the gist of the stomach.
Stomach. Yes, sir.
No, because gist of the stomach, usually they are asymptomatic. The patient will just present with the lump. What are the other presentation because of gist? Apart
Melina,
from the lump, yeah, melena may be there. Why there is a melena?
so because of the GI, the bleed that will be happening.
So why there will be GI bleed in gist? If you look at the pathology of the gist, you can know that why this bleeding is there.
Stromal tumor, sir. So because it's mostly like because of the necrosis and the sloughing of.
So usually because of pressure necrosis is there and sloughing of the central part of the gist,
Right, sir.
that bleeds. You know? So that is the common cause for the bleed in the case of the gist.
Yes, sir.
Okay. So in the spleen, what are the causes you are thinking? You know, you just cannot say splenomegaly by as a diagnosis.
Right, sir.
That is just an examination finding. But what are the things you are going to keep in splenomegaly if it is there?
Um,
Do not keep the ultrasound and all those pictures in your mind.
right, sir.
Just basic on the history and the examination.
Splenic abscess and splenic cyst, and
Does your patient has got the fever?
had intermittently 6 months ago, but not in the past 6 months, sir.
So do you think if the patient has got splenomegaly is there and the
No.
patient only had a fever in the initial phase, can have the splenic abscess?
No, sir. It won't be abscess, sir.
Now, if there is a like a splenitis is there, what other findings you can get on examination?
So, sorry,
There
sir.
is splenomegaly is there
Right, sir.
and patient has a splenitis. What other findings you can get on examination?
The mass would be the lump would be tender
Okay.
on clinical
Yes.
examination.
Movement will be restricted.
Oh, yes, sir.
And when you auscultate, what can happen? In a patient with a splenitis.
Splenitis.
Yes. On auscultation, can you hear something? If the patient has a pleuritis,
The
you auscultate, what you hear?
the rustling the
Okay, that is a pleural rub.
yes, sir.
No?
Rubbing.
And in case of splenitis, what you can hear? That is called as?
Splenic rub.
Yes, it is called a splenic rub. So the same type of it's a type of the scratch sound which you can hear on auscultation. Scratching type of the sound will be there on auscultation. Okay. Why this patient does not have a leukemia or lymphoma?
Sir,
Splenomegaly is there.
again, sir, fever should have been more consistent if because of the B symptoms that are seen in lymphomas. There's no any lymphadenopathy other than this swelling that was examination. Then no other symptoms like night sweats or any weight loss history or
Now, if you think of a leukemia here,
right, sir.
what other clinical finding you will get? Clinical finding. Suspected case of leukemia.
Clinically, the lymphadenopathy will be there. Respiratory distress might be like breathing abnormalities might be seen with patient.
Yes, you can see the bleeding problems may be there. There may be hemorrhagic underneath, the skin may be there.
Yes, sir.
Anything on the bone?
Tenderness could be seen, sir.
Where you elicit the tenderness?
On
In
the
the case of leukemia.
uh,
Where do you test for the tenderness?
on the spine, sir.
No, not usually spine. It is a
On the
tenderness.
sternum, sir.
Okay, on the sternum you get the tenderness. If you look the oral cavity of the patient, what you can get in a case of leukemia?
Ulcers, like candidal infection can be like aphthous ulcers and
You usually get the hypertrophic gingivitis is there. Hypertrophic gingivitis is there. So you look for all the, if you find these things in a patient with a splenomegaly, you think probably of leukemia. What are the findings against to be portal hypertension in your patient clinically? I'm just talking clinically only.
sir, no any ascites, no any dilated veins that were present. Other than that, no hepatomegaly.
What are the two cardinal signs or three cardinal signs of a portal hypertension?
Two cards. Mm.
GI bleed
Yes, sir.
and splenomegaly. These are the two most important cardinal signs. And third cardinal sign is ascites. If you get these three things, your first diagnosis becomes the
Portal hypertension.
portal hypertension. But in your case, it is only the splenomegaly, but there is no bleed is there, there is no ascites. So that is one way you can exclude or you can rule out. You still cannot rule out that, but you will keep the portal hypertension at a lower level there.
Yes.
Okay.
Abhishek,
Yes, sir.
Abhishek,
Yes, sir.
what are the therapeutic manuals to reduce the portal venous pressure apart from drugs? Apart from drugs. In other words, what are the surgical treatment or options for the portal hypertension?
Okay. Sir, TIPS procedure can
Okay,
be
good.
done.
What are tips?
Transjugular intrahepatic portosystemic shunt, sir.
Okay,
Then if not by that, then surgical shunt procedures can be done, sir. Like the Linton shunt, the Warren shunt, and
stapled esophageal transection.
sorry, sir.
Then stapled esophageal transection. Left gastric and short gastric vessels are ligated, and the distal esophectomy is transected and reanastomosis. This is also one of the options given, along with the shunt surgery. Shunt surgery is also there.
Yes, sir.
How shunts are classified? And one more is the arthrotropic liver transplantation. It is useful in advanced liver diseases. These are just theoretical questions, but practically What are the how shunt surgery are classified? Just now you give the examples.
The
Baron and one more. Just now you answered.
Clinton, sir, the proximal and the distal splenomegaly shunts.
Selective, non-selective.
Selective, non-selective, yes, sir.
Selective, non-selective shunts.
Hmm. Yes, sir.
So why this classification is there selective? What is meaning of selective and non-selective?
Sir, the non-selective does the complete bypass, sir, and where the selective will bypass the left, like the one part of like bypass.
What will help? How it helps non-selective shunt? So indirect, in other words, what are the complications of the selective non-selective shunt?
Sir, encephalopathy can be
Very good.
seen in non-selective shunts because the entire thing is
Okay.
bypassed. Yes, sir. And
Abhishek, don't be tense. You are knowing this topic. Huh? Just think and answer.
yes, sir.
This is just one rehearsal for your final exam. Don't be tense. How will you manage ascites?
Initially,
Because all these are 3 PG questions. How will you
yes,
manage ascites?
pharmacologically with pharmacological drugs, I'll initiate and diet restriction of salt will be advised to the patient. Along with that, diuretics can be started for the patient, sir.
Again, surgical treatment.
Um, Sir, tips will will be helpful in ascites for this patient, sir.
Just go through all these points.
Yes, sir.
Okay, go ahead with your this thing for the presentation.
Further, sir, patient had already had investigations of USG, which was suggestive of a splenic cyst. At our institute, we performed a CT scan as well of the patient. These are the CT slides for the patient, which was suggestive of a multiloculated cyst present in the spleen, sir. It was also the size was around 9 by 8 by 8 centimeter. There were septations present within it, and it was also having mass effects on the upper pole of left kidney and distal pancreas.
Abhishek, what are the various types of splenic cysts?
There can be true cysts and false cysts, sir. True cysts like the epithelial cysts, sir, and epithelial inclusion cysts can be present. False cysts, the pseudocysts, or yes, sir.
What is the commonest cyst of the spleen?
The simple cyst, the benign cyst is the most common, sir.
After that,
Um, I'm not sure, sir.
is your case a case of hydrated cyst of the spleen or not?
Yes, sir.
Mhm.
Most likely, not yet completely. Yes, sir. It looks like hydrolysis, sir.
So what are the findings of the hydrated cyst? on CT scan?
It is irises are multiloculated. There would be septations, calcifications can be seen. Daughter cysts might be
Yes.
visible in these cysts.
And what will happen to the wall of the cyst? What can happen to the wall of the cyst?
Um,
It can get calcified.
yeah, yes, of course.
The wall can be calcified. Yeah. So what was the radiologist's opinion in this? What did they say what it is?
So they have just they have given that it is a multilocular cyst with septation, most likely a hydrated cyst.
Okay. So if they're given the opinion of hydrated cyst, what you are going to investigate further?
Sir, serologically, I would like to confirm it.
Yes. Have you
And
done that?
yes, sir.
Has it been done?
It has been sent. The patient has been admitted right now, so it has been sent for the patient.
So which serology you are doing?
Sir, IgG for echinococcus has been sent, sir.
Any other test which was done in the past for the hydrated cyst, not done nowadays?
The Cassony's test, which was done earlier, but not performed now.
What is the problem with the Cassini test?
The hyper sensitivity that can be seen, sir.
Right.
Type 1 hypersensitivity.
So from where the hydrated has come in the spleen?
Sir, the psych possibly the patient would have ingested the eggs, and when the larvae entered the lamina propria of the intestine and then entering the vascular channels, it would have uh, entered the spleen, sir.
So which is the first filter for this?
The liver, sir.
And second filter?
Lungs.
Lungs, pulmonary circulation. No, yes. And then it can go to the systemic circulation,
Yes, sir.
and it can spread anywhere. Anywhere in the body, you can have the hydrated cyst.
Yes, sir.
Okay. Any other investigation you have done in your patient? Have you looked for the CBC of this patient?
Yes, sir. It is within normal limits. Like there's
What
no
you're looking for?
No, sir. Nothing, sir.
What did you see in the CBC?
Sir, the WBC counts where the eosinophilia was not there, sir, in this patient. Like I was
You are mainly looking for the eosinophilia.
eosinophilia, but it wasn't there, sir.
So, keeping hydrated cyst as a possibility, what is your plan?
Sir, there will be plan is to do a splenectomy, sir, for this patient, as it's very huge and compressing the other organs around it. Plan is splenectomy, sir.
Okay.
Patient.
So before you go for a splenectomy in this patient,
Yes, sir.
are you going to prepare your patient?
Yes, sir. Electively, vaccination has been given to this patient.
Okay. What else? The
Sir,
vaccination, what other preparation you have to give? Your patient is a case of hydrated cyst, isn't it?
Yes, sir. Albendazole has been started to the patient, sir.
It has to be given, no?
Yes, sir.
Because why you want to give it pre-operatively also, and even the post-operative? The reason for that?
Abhishek, initially you told there is calcification.
No, sir. There's no calcification.
Okay, there is no calcium. If it is calcified, then what it suggests? Suppose it is calcified, what it suggests? Any idea?
No, sir.
To be live or dead?
Dead, sir.
Huh?
Dead. Yes, sir.
Okay. So what are options you are having to treat this case? Various options, then pros and cons. What are latest guidelines this type of cyst to manage?
Sir, a partial splenectomy can be done, but looking at the size of this
So I'm asking what are various options you are having?
pair is usually possible, sir. Pair can be done. Percutaneous aspiration, inspiration, and re-aspiration.
Can you explain further? Where?
Sir, in this procedure, we inject scolicidal agent, and then afterwards we
Sequentially, you have to tell what exactly is being done there. Directly you inject?
no, sir. I mean,
What is
initially we puncture.
full form of pair?
Sir,
PEIR. What is
puncture,
it?
aspirate,
Percutaneous
percutaneous
aspiration
aspiration, injection, and re-aspiration.
re-aspiration.
Yes, sir.
What is instilled inside?
Sir, different scolicidal agents can be used, sir. Like hypertonic saline can be used. Then the cetrimide can be used, sir, and 10% betadine has also been tried, sir, in this patient, like a pair.
Okay. What are other options? So nowadays there are multiple options. It's not that difficult.
Right.
Hmm?
I'm not sure, sir.
Not sure. In splenectomy, by different approaches, it's causing too much external pressure on other organs, discomfort. It may get infected. It may turn into an abscess. It's quite huge, no?
Yes, sir.
Then what are options? Surgical options. Can you treat with laparoscopy?
Yes, sir.
Laparoscopic approach,
Laparoscopic
open
attack.
surgical approach. If you don't have adequate exposure to laparoscopy, you can go for the open.
Laparoscopic or a robotic approach can be.
Can radiologist help you? How long you will give albendazole to such patients?
Sir, preoperatively, for like 2 cycles of albendazole preoperatively will be given, and postoperatively it will be continued again, sir.
How long?
Postoperatively, one cycle, sir.
What are complications if not treated?
Oh, sorry, sir.
If it is not treated, what are complications likely to develop?
Sir, patient, there could be rupture of the cysts causing peritonitis or other organ abscesses. Um, and
Okay, we can wind up your case. So you have to know different various options of treating hydrated cyst of whether it's a spleen, liver. Liver is most common in other areas. It can happen at various sites very rarely.
yes.
Okay, it's good case.
Thank you, sir.
Abhishek, don't worry. You answered most of the questions.
Yes, sir.
Don't be serious.
Yes.
Dr.
Sir, shall we
Abhishek, do
move
you
to
have
next?
any? Yes, sir,
next
please.
case?
Abhishek, do you have any doubts to get clarified with the faculty here?
Sorry, sir, I couldn't hear you, sir.
No. Do you have any doubts to be clarified with the faculty here?
Sir, what other, like, if not splenectomy, like, but what else was, like, can be, is it possible for this patient, sir?
Partial pericystectomy can be done, either open or laparoscopic approach.
But, sir, if it's like
Partial pericystectomy. We can-
recurrence and like in spleen.
How to see how much spleen is there.
Okay.
Otherwise, we can go for splenectomy. It is already destroyed. Everything is destroyed.
Yes, sir.
If you want to conserve spleen, if spleen is there, you can go for pericystectomy. That we do in case of liver also.
Right, in liver.
How to manage that cavity? This big cavity, how to manage that? There's another thing.
Sir, omentopexy
Omentopexy.
can be done.
Omentopexy.
What is capitonage? Okay, find out.
Yes.
Any other?
So, thank you. Kanna sir, can we move to the next case, sir?
Yes, sir.
Yes.
Just telling about this case, yes, sir.
Yes, sir, please, sir.
Yeah, depending upon the type of the hydrated cyst, at what type of the hydrated cyst is there, you can take it as a radiological intervention, or you can go for the surgical intervention, or just the medical intervention.
Okay.
So if you do not find any daughter cysts inside that, just the fluid is there, you can do the pair technique even in the spleen also. Okay, as you do in the liver, the same can be done also for the spleen also.
Okay.
If it's a small cyst which is there, which you think is not very harmful, you can continue with the medical treatment of these patients. And the surgical intervention can be the open surgery or it can be laparoscopic surgery. Okay, in either of the cases, depending again what is the location of the cyst, whether it in the polar location is there or the central hydrated cyst is there, then you have to decide, can we go for the partial splenectomy or you have to go for a total splenectomy in these patients. Sometimes there are a lot of adhesions which are there. So you do the same as you do in the liver, that you just do the enucleation of that. And then you can do the what is called as a decapitation of the cyst. So you decapitate the bulging part of which is there, the cyst is there, you just cut that and remove the entire content from inside. Just like in the liver you do, same can be done also in the spleen. But majority of the time, like in your patient, probably the splenectomy will be required because it's a big spleen which is involving the central part of the spleen. Okay. Yeah, Dr. Kanagavel, you can go for the next case, yeah.
Yes, sir. Thank you, Dr. Abhishek. Thank you for joining. You can stay with us for the next discussion. Dr. Madhu. Dr. Madhu.
Yes, sir.
Yeah, Madhu, madam is joining. Madhu, I don't see her. Still, she's on call.
Yes, sir. I will confirm.
No, I will try to speak to her. You please introduce yourself and start your presentation. Good luck to you.
Okay. Okay. Thank you. Sir, I'm just sharing the PPT.
Please start sharing the PPT. Make it full screen, Dr. Madhu.
Yes, sir. Very good.
Good luck to you.
Good evening, everyone. This is Dr. Madhu. I'm
Madhu,
from-
we are unable to see you. Please switch on your video, ma. Yes, now you start present. Good luck.
I'm unable to share PPT.
Yeah, you are okay.
So PPT
PPT is seen.
it is not showing in my laptop.
You please unshare the PPT. Now press share button. What are the windows you are getting?
Awesome.
Are you able to see the PPT in your screen?
Yes, sir.
Good luck.
Thank you. This is Dr. Madhu. I am from James Gopal. I am postgraduate second year resident. Now I am going to present a case on breast cancer.
Okay, all the best.
Thank you, sir. A 35 years female patient, housemaker by occupation, resident of Bhopal, Madhya Pradesh, belongs to low middle socioeconomic status according to modified Swami classification, presented with a chief complaint of lump in the left breast for 1 year and pain in the left breast from 3 months. The patient was apparently well 1 year back when she noted a lump in her left breast, which was insidious in onset, gradually increasing. Initially small in size of about 1 into 1 centimeter, and it progressed to attain a present size of 10 into 10 centimeter. And from the last 3 months, patient was complaining of pain in her left breast, which is intermittent, pricking type, moderate intensity, relieved on taking medication. And there is no history of nipple discharge or trauma to the breast. There is no history of fever. There is no history of loss of weight or loss of appetite. And there is no history of bone pain, cough, breathlessness, jaundice, headache, vomiting, or convulsions. And coming to the past history, there is no history of tuberculosis contact. There is no history of taking oral contraceptive pills or hormone replacement therapy. There is no history of chronic medical illness or breast surgery or biopsy in the breast. There is no history of radiation exposure. There is no history of any drug allergy. Coming to the personal history, patient is on mixed diet, normal bowel and bladder habits. There is normal sleep pattern, no history of any addiction. Family history, there is no history of breast cancer in first degree relatives, no history of BRCA related malignancies in the family, like pancreatic, prostate, colorectal, or ovarian. Coming to menstrual history, She attained menarche at 14 years of age. She had regular cycles of 28 plus or minus 2. And she married at the age of 22 years. She had 2 children. Both the children are delivered by normal vaginal delivery. Both the children are breastfed till 1 year of age. And the first childbirth is at the age of 23 years. So, summary: a 35 years female patient presented with a breast lump since 1 year, and from the last 3 months, patient is also complaining of pain in her left breast with no other positive history. So shall I continue with general examination?
Okay. According to your history,
Sir.
she has any risk factor?
Sir, no such risk factor, sir.
No risk factor. Then what is there?
Sir?
There is no risk factor. Then why she should get this lump in breast? If at all it is malignant.
She might have a family history that she might have not remembered.
Like, as
Sir,
per
most of the cases are sporadic.
Hmm?
Most of the cases are sporadic. Breast lump.
Okay. Go to the first slide. One year duration, pain 3 years. Okay. So over the period of 1 year, it increased how many times? 10 times almost.
Sir.
Okay.
The patient has taken Ayurvedic treatment outside, sir.
But this lump progress almost to 10 times.
Yes, sir.
What does it indicate?
I could suspect malignancy, sir. It could be a malignant lump.
Okay. Go to next slide. So you are saying there are no risk factors, but being female itself.
Female is a risk factor.
Huh?
Being female is a risk factor.
Okay. Next slide. You have written history of OC pills and HRT. Okay. What is the role of OC pills nowadays?
Sir, previously they were using high dose of
how much role it plays?
Sir?
How much roles it plays as a risk factor?
Relative risk is around 1.1.
Huh?
Relative risk is around 1.1.
Is it significant?
Sir, no, sir.
Huh?
No.
And what about HRT?
Hormone replacement therapy, high doses of estrogen can increase the risk.
So what is it related to any duration of HRT or just taking HRT is enough? Duration?
Increasing the duration definitely increases the risk of
Means how much?
Yeah. No idea.
Huh?
Exact years.
Minimum period. You have written history of any surgery or biopsy in the past. What is significance of this statement?
Any previous history of breast lump that might have taken biopsy could be atypical hyperplasia that might have progressed to present condition.
So, if there is any history of any benign condition in the past,
sir. Sir.
What type of conditions you expect? Biopsy is done, and what type of changes? If you come
atypical
across,
hyperplasia.
huh?
Atypical hyperplasia.
Atypical
hyperplasia biopsy specimen.
So, just being atypical ductal hyperplasia is sufficient? Any specific thing in that?
Nuclear marks.
So, what are grades? According to grades, how it increases, how much risk is increases, it causes increase in the risk of the You're talking about ADH, na? Atypical ductal hyperplasia.
Yes, sir.
Okay. So when you say there is hyperplasia, because you have to ask your pathologist to look for this. Even you are operated on benign cases like fibroadenosis. So you have to look for very diligent search for the ADH. If it is mild, whether it may not matter. So what are grades which can increase the risk?
If there any pleomorphism or increase in mitotic rates, increase in mitotic number, pleomorphism.
No, here is hyperplasia. Moderate or severe or hyperplasia is very important. If lady has undergone surgery for some fibrocystic disease, what are the changes you are interested to know, whether they are there or not? If they are there, you have to be careful. We have to tell patient. That's why, because we have to know the history of biopsy or any surgery, the breast.
Okay.
We change in case of this. Understood what I am asking? If patient is operated for any benign condition, pathologist has to look for such changes. There is moderate or severe ADH. Understood?
Yes, sir.
Okay. Next.
Madhu, what are the various risk factors for the breast cancer?
Sir, early menarche, late menopause, smoking,
Tell
alcohol.
the absolute risk factors. There are two types of risk factors are there, absolute and relative. So what is the difference between these two, absolute and relative? Absolute is if the risk is more than 1.5 to 2 times.
Okay.
If it is less than 1.5 times is there, then they are relative risk factors. So tell what are the various absolute risk factors?
Absolute risk factors, previous family history, sir.
Family history, yes.
Radiation exposure, previous radiation exposure.
That is usually not. What else?
Early menarche, late menopause.
That is also not absolute.
Genetic predisposition.
Yes, genetic can be there. BRCA1, BRCA2 is positive, yes.
BRCA1, BRCA2 mutation.
Right, yes.
Female sex.
Female itself, yes. And age of the patient.
Increasing in age.
Yes. So age of the patient, family history. If the patient herself had a breast cancer on one side,
yes,
with a BRCA1, 2 is positive, and the previous biopsy of a benign condition showed the atypical ductal hyperplasia. So these are the 5 or 6 absolute risk factors. While all others which are there, like early menarche, late menopause, nulliparity, lactation,
tobacco,
alcohol, obesity, all those are relative risk factors. And the highest risk factor which is there is there's an atypical ductal hyperplasia is there in the previous biopsy, plus there's a family history there. Okay, it is almost 9 times more risk of having the breast cancer. Okay, so that is the highest risk which is there. Combination of atypical ductal hyperplasia plus the family history which is there. Then there are called as modifiable risk factors and non-modifiable risk factors. What are those?
Sir, modifiable risk factors are obesity, tobacco use, alcohol consumption, radiation exposure. Non-modifiable risk factors are age, gender of the patient, family history, genetic predisposition.
Right.
And
so usually all the absolute risk factors are non-modifiable.
Yes, sir.
While the relative risk factors which are there, you can modify them there.
Yes, sir.
You know, how much time does it take to be having a 1 centimeter lump in the breast? It depends on the tumor doubling time. If you can know about that tumor doubling time, then you can tell that. Because your patient had 1 centimeter lump initially, and in 1 year time, it has become 10 centimeters.
Yes.
So how much is time it has taken to make it 1 centimeter? What is the tumor doubling time for the breast cancer?
So, no idea.
Okay, it is around 100 days. Approximately 100 days. And for becoming from 1 cell becoming 2 and 2 becoming 4 and 4 becoming 8, it takes 30 alterations. And that 30 alteration will make it 5 years. Okay, so 1 cell becoming a 1 centimeter palpable lump which is there, it has already been there for 5 years, based on the tumor doubling time of 100 days. Okay, and once, you know, as the size increases, then the doubling becomes very fast. So 1 centimeter becoming 2 centimeter, 2 becoming 4 centimeter, 4 become, so it will take a very short time in that.
Okay.
Only 100 days is taking that. So that is why a centimeter lump can become 10 centimeter lump within a year's time. Okay.
Okay.
Right.
So one more factor regarding parity of the patient.
Yes, sir. There is increased risk in nulliparous women, sir.
Why? What is the explanation for that?
The pregnancy is a protective factor, sir. Nulliparous women, there will be unopposed action of estrogen. So,
So what should be the age of the first pregnancy
sir, less than
to give protection against this?
no, sir. First pregnancy less than 25 years.
25?
More than 20 years. Less than 20 years.
Less than?
20.
Okay. It has to be full-term pregnancy.
Full-term pregnancy.
Yes.
Dr. Madhu, are you aware of any risk prediction models in breast cancer?
Gale model.
What do you see in Gale model?
No idea.
So there are
This
age,
model, no.
again age at first menstruation, plus first birth child. When was the first child was born? Family history, number of past breast biopsies, and number of breast biopsies showing atypical hyperplasia. And also the ethnicity, race of the patient is also a risk factor. So breast cancer is common in Western population, what we call as Caucasian population, ethnicity, and relatively less common in Asian as per the data, but it is changing. In the last data is saying something else, but that is we need to look into it. So, and what are the genetic mutations you know in breast cancers you can think of? Are you aware of mutations which are common in breast cancers? You said BRCA mutation, hello?
Sir.
So what are the mutations you see in the breast cancer? Yeah. Other than BRCA, you can think of anything else?
P53 mutations.
Yeah, P53. That is germline mutation. Okay. Ever heard of CDH mutation? CDH1 mutation. So CDH1 mutation is associated with lobular carcinoma breast along with CA stomach. So diffuse gastric cancer and lobular carcinoma breast. It is lot more common in patients with CDH1 mutation. Other than there are few more PMSH2 mutations. Plus, so there is a big list of those mutations. I think you should go through that. But these are the common ones. Yeah.
Okay, go ahead.
Coming to general examination, patient was examined in a well-lit room after taking proper consent with adequate exposure with female attendant. General condition: patient is conscious, coherent, cooperative, oriented to time, place, and person. Average length of 152 centimeters, and BMI of 19.5, and ECOG score is 1. There is no pallor, cyanosis, icterus clubbing, or pedal edema, and generalized lymphadenopathy. And pulse rate is 80 beats per minute, regular rhythm, normal volume and character. BP is 118/76 in the right arm in supine position. Respiratory rate is 18 per minute, and it is regular. Temperature is epidemic. Coming to local examination, right breast and axilla are normal. Coming to inspection of the left breast, with arms by the side of the patient. Left breast appears larger compared to that of the right breast. And there are two lumps are noted in the left breast. One lump, first lump, it is in the upper inner quadrant of about 6 into 5 centimeters, extending from 9 o'clock to 12 o'clock position, and 3 centimeters away from the nucleolaryar complex. And skin over the lump is shiny, and redness is noted. Another swelling is noted in the upper outer quadrant away from the main lump from 2 o'clock to 3 o'clock position, and 5 centimeters above and lateral to the nucleolaryar complex. The separate nodule is noted towards the lateral border of the main lump, mostly a satellite nodule, and a puncture scar mark was visible over the lower lateral border of the main lump, and the nipple is deviated outwards and downwards, lower when compared to the right side. And circumferential nipple retraction is also noted. Inspection of the breast with arms raised over the head. The lump becomes more prominent when the hands are raised over the head, and there are dilated veins noted over the breast. The areola, there is no cracks, fissures, ulcer, or eczema. On pressing the hands against the waist, lump becomes more prominent, and on leaning forward, left breast does not fall freely when compared to that of the right breast. Coming to palpation, there is no local rise of temperature over the lump. Two lumps are palpated in the left breast. Main lump of 15 into 8 centimeter, non-tender in the upper inner quadrant, hard in consistency, with irregular surface and well-defined margins, extending from 6 o'clock to 12 o'clock position, involving the medial border of nucleolaryar complex. And the lump is fixed to the breast tissue. Lump moves along with the breast tissue, not independent of the breast tissue. Lump mobility is decreased on contracting the pectoralis muscle, and there is no fixity to the skin. There is no dimpling or puckering noted on moving the lump. Second swelling of about 2 into 2 centimeters noted in the upper outer quadrant with irregular surface, well-defined margins, hard in consistency, extending from 2 o'clock to 4 o'clock position, 3 centimeter lateral to the main lump, and 4 centimeter above and lateral to the nucleolaryar complex. And 1 into 1 centimeter satellite nodule is palpated on the lateral border of the lump. Axilla, single anterior group of lymph node is palpable of size 2 into 2 centimeters, hard, mobile, and non-tender. And another single central group of lymph node is palpable of size 3 into 3 centimeter, which is hard, fixed, and non-tender. Coming to systemic examinations.
Shall we stick to the local examination first? Can you show the breast, that picture again? This, yeah. So, why do you examine the normal breast first?
The part of examination, we go from the normal first. We examine the normal side before.
What information it gives? It should be giving some information, no? That's why you do it first.
We can get the texture of the other breast on palpation.
Okay. So breast has, if you see, every breast has a different consistency. They have different combination of glands and
Yes.
fat.
Yes, sir.
So first you have to know that what is the normal breast in this patient. What is the feel of normal breast in this patient. Also, another reason is not necessarily that patient will notice there is a, what is the incidence of bilateral breast cancers or bilateral breast lumps?
Around 5%.
And what are the, do you know where are it is more common? What are the histologies or anything? Any idea when it,
Triple negative breast cancer.
okay. Also lobular breast cancers, they are more common.
Lobular.
Eccentric. So that is also, sometimes you may find a null palpable lump in a normal appearing breast. So always examine both the breast and axilla.
Yes, sir.
And what are the areas you examine? You examine breast and
Breast and axilla. Inframammary fold.
and
Opposite
only,
breast and axilla.
what is the other important area? You have to examine supraclavicular fossa, because supraclavicular lymph nodes, they come in regional lymph nodes in breast cancer.
Yes, sir.
Okay. So
Yes.
supraclavicular lymph nodes on both sides, that has to be examined.
Yes, sir.
Supraclavicular lymph node is N3 disease actually in breast. So always examine, make it a habit to examine normal breast, bilateral axilla, and bilateral supraclavicular fossa also. And obviously, the general examination, you see other lymphatic areas also, but for this breast cancer, supraclavicular fossa is a regional area, not, it's not like a metastatic. So that, and you said there is no nipple retraction.
The circumferential nipple retraction occurs.
Okay. So you think it's a two separate mass or some lump, or it's a one lump having two retraction?
Two separate lumps are palpable in the breast. One in the upper inner quadrant and the upper outer quadrant.
And you examine the patient in what positions? You did not mention. I think you mentioned, or I don't remember. But what are the positions you examine them?
Sir, supine position, sitting position, semi-recumbent position. I have examined.
And
Arms by the side, arms above the head, and
okay.
arms
So what is
pressing
the most
against the
important position? Which one you should never miss? I mean,
semi-recumbent position.
no, actually it's a supine position. So breast lumps, they are always palpated
Sir,
against a firm background.
sorry to trouble you, sir. One moment. Can you just forward this slide out of the other slides, ma? Because YouTube will ban us. So please advance the slide to your then you can talk. Sorry, faculty, because this
Yeah.
becomes a challenge for us. Please continue the questioning.
Yeah. So what we have supine position. So supine breast lump is always palpated against a firm background. That is your chest wall. So not for this lump, but smaller lump or vague lumps, you have to feel them against the chest wall.
Yes.
So the supine position is the most important position for a breast examination. Okay. And also you should see what are the hidden areas in a breast examination where you tend to miss few things.
Inframammary.
Inframammary crease is one area. So that is where you see the arm raised,
Above the head.
that exposes the inframammary crease.
Yes.
Okay. Anything? And you said skin change. Are there any skin changes?
Sir,
What are
there is
the
redness.
breast?
Hello.
What are the skin changes you get in breast cancer? What does this signify?
Sir, we can get ulceration, satellite nodules, cloudy orange appearance, which says that the skin is involved.
Okay. Do you think retraction is skin involvement?
retraction of nipple is not a skin involvement.
PDO is skin involvement.
Sir, PDRN is a skin involvement.
So what does it signifies?
Sir,
Why
it
do
is
we
due
get
to the blockage of dermal lymphatics and due to the infiltration of tumor in the axillary nodes, there is impairment of drainage. So there will be lymphedema.
okay? Okay, fine.
You told satellite nodules are there.
Yes,
Yes or no?
yes, sir.
So what are those nodules?
Sir, satellite nodule, we will see on the skin, which is separate from the main lump.
They
It is
suggest
more
what?
than, it suggests skin involvement.
Okay. If there is diffuse involvement of chest wall skin, what is it called?
Sir, inflammatory breast carcinoma.
Hmm?
Inflammatory breast carcinoma.
No. Chest wall involvement. Entire.
What is inflammatory breast cancer?
Sir, in
You know-
inflammatory breast cancer, there will be no lump palpable, but there will be polyarrange appearance, and there will be redness more than 1/3 of the breast, involving the more than 1/3 of the breast.
No, lump is not the criteria. There may be lump or may not be lump. It's not that there is no lump. So the criteria which AJCC gives is the erythema should be
more than 1/3.
That is the only thing. Okay.
Yes,
So, yeah.
How will differentiate between the mastitis and carcinomatosa mastitis? Inflammatory carcinoma and just mastitis. How will differentiate?
mastitis is in engagement.
It almost looks like
There will be history of
same.
fever.
Almost looks same. So
Yes.
what is the difference? Without biopsy. What is not there in mastitis carcinomatosa?
Fever.
Yes. Right.
There will be fever in mastitis.
Yes, you're right. Go ahead.
Now, Abhishek, you have written in your journal examination BMI 19.5 meters square. What is that?
Body mass index.
Can you go to your general examination slide? What is this 19.5 meters square?
BMI, just BMI, sir.
Yeah.
BMI is a number, sir. Not I. It is by mistake.
So either you can write kilogram per meter square.
Yeah, kilogram.
It is okay, na? But not just the meter square, na? Or you do not write anything. Right. Now, when do you say the lump is fixed to the chest wall? What is the clinical finding to say that lump is fixed to the chest wall?
Sir, we'll ask the patient to press the hands against the waist, sir. We'll check we ask the patient to press against the waist, hands to press against the waist, so that the pectoralis major get taut, and we'll move the lump over the chest wall, sir.
You know what is chest wall?
Yes, sir.
What do you
Chest wall
understand with chest wall in relation to the CA breast?
Sir, chest wall means intercostal muscles, ribs, and serratus anterior.
Okay. So if the lump is fixed to the either of these things,
Sir.
Will that lump be mobile or not?
Not mobile, sir.
So if the fixed lump is there, then it is fixed to the chest wall.
Yes, sir.
But if it is a mobile lump on the outer aspect, what does that mean? If the lump is there in the lower outer quadrant,
Sir.
Will that lump be mobile or fixed in a case of fixed wall chest wall?
It will be mobile.
So how will you say it is fixed to the chest wall?
We cannot move the lump, sir. will be fixed.
No, that is non-mobile lump. See, if in the breast, if the lump is not mobile, it is for all practical purposes, it is fixed to the chest wall, except in the lower outer quadrant, where if it is lump is there, it is still fixed to the chest wall if it is fixed to the serratus anterior. So you have to ask the patient to press against the wall to see for that.
Yes.
Otherwise, you do not require to make any muscle taut. You are making the muscle taut for what? Seeing the fixity to
Pectoralis major.
pectoris major. So that is not the chest wall.
Okay. Okay.
What are the various T4B lesions? What do you understand by T4B?
T4B means involvement of the skin, sir.
Yes. So what does that mean?
Sir, any satellite nodules on the skin, any ulceration or podarenge appearance.
So what do you understand by satellite nodule? What is the meaning
Satellite
of
nodule? Sir, it is a separate nodule seen over the skin away from the main lump.
like in a case of melanoma? Okay,
Melanoma, satellite
you
nodule.
have a satellite nodule and you have an in-transit nodule. What is the difference between these two?
Sir, less than 2 centimeter, it is satellite nodule. More than 2 centimeter, transit nodule.
If it's the nodule is within 3 centimeters of the main lump, that is a satellite nodule.
Yes.
If it is outside that, then it is the in-transit nodule.
In the transit nodule.
Now, what are the various skin changes can occur because of the breast cancer?
There will be ulceration.
Ulceration, yes.
Satellite nodules.
Satellite nodule, yes.
And podarenge appearance.
Podarenge, yes.
If the breast is very large, you can see skin changes like dilated veins.
Okay.
The skin becomes thin and it will become shiny over the breast line.
Puckering.
Puckering, dimpling are also. These are
Dimpling,
palpable findings.
All these are the skin changes.
Skin changes.
What is armor chest?
Cancer and cuirass.
Cancer cuirass is also a skin change.
Yes, sir.
Okay. Then there may lymphedema may be there. So all these are the skin changes which can occur. But of all these changes, only the satellite nodule, pudor orange and ulceration is taken into T4B category.
T4B. Yes.
Okay, go ahead.
Hello, Madhu.
Sir.
How you explain the skin dimpling? What is pathophysiology behind it?
Sir, infiltration of Cooper's ligament by the tumor. Infiltration of Cooper's ligament by the tumor causes dimpling and puckering.
Breast, that is Cooper's ligament.
Yes.
Which connect it and malignancy infiltrate that.
Sir, we didn't get the question.
Hello?
Sir.
Lobes of the breast are separated by the fibrous septa. That is suspensory ligament of the breast.
Cooper.
And malignancy infiltrate the structure and that causes
dimpling or
dimpling. What are the other skin manifestation of the CA breast? This is full question for PG exam. Very question.
Other skin manifestations.
And it is commonly asked in DNB exam also.
Sir, other skin manifestations of satellite nodules, podarenge appearance, ulceration.
Okay.
And dilated veins over the breast line.
Okay.
Dimpling and puckering noted on the skin. Hello. Hello.
Okay, Madhi, go ahead with your examination part. Finish your examination.
Regarding arm,
Madhu, are you there?
Ah, sir, I'm there.
Yeah, go ahead with the examination. You have finished all this.
Yes, sir. Coming to systemic examination,
Yes.
examination of thoracic spine is normal, abdomen is normal, and per vaginal per rectal examination within normal limit. And
So
summary,
you
sir.
have examined only the thoracic spine. Is that the common site for the metastasis?
No, sir. Lumbar spine is the common site of.
So why did you write only the thoracic spine?
Lumbar spine is the most common.
Yeah, lumbar is much more common, no?
Yes, sir. Yes, sir.
How did you examine the spine?
Sir, I check for paraspinal tenderness.
Why paraspinal? Why not on the spine? Why the paraspinal and why not on the spine itself? What is the site of metastasis in bone
Lumbar.
in the vertebra? What is the site of metastasis in the vertebra?
Transverse process.
Not in the transverse process.
Vertebral body.
Yeah, in the vertebral body where? The pedicle is there.
Pedicle.
The pedicle. How do you see the pedicle on plain X-ray abdomen? Plain X-ray, if you're doing? How do you see that? How does it look like? Okay, the rounded structure. You will see the two rounded structures on the upper side of the body of the vertebra. Just like the buffalo eye sign. Okay. So that is the site of that is why you do in the paraspinal area, not on the spine.
Okay.
What are the things you are interested to palpate in the abdomen in a case of CA breast?
Sir, any Abdomen?
Yes. What else?
Any ascites?
Yes. What else? Why you have done the PV examination in this patient?
For any metastasis, we look for any metastatic lesions.
Where?
In pouch of Douglas. In pouch of Douglas.
This lady is premenopausal.
Yes, sir. Premenopausal.
So what do you look up?
Any lesions in pervaginal examination?
What lesion?
In pouch of Douglas, if there is any mass.
But for pouch of Douglas, do you do PV examination or you do the PR examination?
PR examination.
So why you are doing the PV examination? And the abdominal examination? Lower abdominal, why you want to examine the lower abdomen? Any structure apart from the uterus?
Ovaries.
Yeah. So what will happen to the ovaries?
So any Krukenberg tumors, metastasis.
Yes.
Tell that. You have to tell about that Krukenberg tumor.
Yes.
So tell what are the various characteristics of a Krukenberg tumor?
It is bilateral.
It is bilateral, yes.
It is seen in premenopausal.
Seen in premenopausal, good. Is it a solid tumor or a cystic tumor?
Solid tumor.
Solid tumor, right? Yes. So bilateral solid tumor in a premenopausal female is likely to be the Krukenberg tumor. Can it occur in the postmenopausal also?
No, sir.
It can occur, right? It can occur in the postmenopausal. Then what is the way of spread? How does it reach to the ovaries?
The transcoelomic spread.
No, transcoelomic is for the premenopausal. But you can also have the retrograde lymphatic spread may be there. Retrograde lymphatic spread may be there, and that may be cause for the postmenopausal, and also in the premenopausal it can occur there. Okay. Did you examine the CNS of this patient or not? Central nervous system. Can anything happen in the central nervous system in a patient with a CA breast?
I have taken history regarding any CNS symptoms like headache, convulsions.
Okay. What are the various features of increased intracranial tension? What are the three cardinal features of that?
Neck rigidity.
Not the neck rigidity.
Hypotension.
Yeah, that's what I'm asking. What are the three cardinal features of a raised intracranial hypertension? Headache will be there.
Headache.
And second?
Hypotension.
You mean the normal hypertension? The blood pressure will be high?
Low blood pressure will be low.
No, you don't get that. Okay, it is a headache. It is a vomiting. It is the papilledema.
Projectile vomiting. Projectile vomiting.
Headache, vomiting, and papilledema. These are three cardinal features of a raised intracranial tension. And then there can be focal deficits may be there. Okay, as a case of the CNS manifestation there.
Yes.
Okay. What are the things you will see in the chest examination? You are not told anything about the chest here in the systemic. What are the things you see in the chest examination?
Any decreased breath sounds.
Okay.
In the history, any history of hemoptysis.
Okay. Examination part. In the examination?
Any dull note.
Yes.
On percussion.
Okay. If there's a dull note, percussion is there. What it can be?
It could be a metastasis to the lung.
No. What pathology will be there in the thorax? Or in the lungs?
It could be any solid mass in the liver, in the lung, causing dullness.
Consolidation may be there.
Yes, sir.
Or there may be pleural effusion may be there. Okay.
Yes,
there is pleural effusion is there, consolidation is there. Both are dull on percussion. So how will you differentiate whether it is consolidation or it is the pleural effusion?
Change in position.
Nothing will happen. You will do the vocal resonance and the vocal fremitus.
Okay.
So what will happen? What will be the difference in these two?
Increased in solid mass.
In case of consolidation, it will be increased.
Yes.
In case of pleural effusion, it will be decreased. So by that way, you can differentiate whether it is a consolidation or it is a pleural effusion is there.
Yes.
Okay. So go to your final diagnosis. Okay, yeah, tell about that. Tell the history. Tell about that summary.
37 years, premenopausal lady with a lump in the left breast since 1 year, gradually increasing in size, with no history of nipple discharge or any history of distinct metastasis. No, without any history of menstrual irregularities, abortion, miscarriage, or hormone replacement therapy. On examination, 2 lumps noted in the left breast of 15 into 8 cm, hard lump in the upper inner quadrant with a regular surface and fixed to chest wall. Another swelling of 2 into 2 cm in the upper outer quadrant, hard in consistency, with satellite nodule on the skin with collar hole and fixed regularly. And my provisional diagnosis is a 37 years premenopausal lady with carcinoma of left breast with clinical staging of CT4B N2M0.
You are saying it is fixed to the chest wall.
No, sir. No, it is not fixed to the chest wall.
You have written there, no? It is fixed to the chest wall.
Not fixed.
With irregular surface with fixity to the chest wall.
Yes, by mistake.
Okay, it is not fixed to the chest wall. Okay.
No, sir. No.
Okay. Yeah. So it is What do you understand by C? What is that?
Clinical staging, sir.
What are the other prefixes which are done in the TNM staging?
Sir, why, sir? Neoadjuvant chemotherapy will use Y.
Yes. Then anything else? Any other prefixes which can be put?
P pathological.
Yes. Anything else?
Small R recurrent.
A. What is A? If you put autopsy, yeah.
Yes.
Okay, so it can be C, it can be P, it can be Y, it can be A.
Yes.
Right.
According to your the staging, which group of treatment it falls?
Sir, it is locally advanced breast cancer.
Locally advanced.
Yes.
So what will be the aim of treatment?
I will discuss the case in MDT before starting the treatment.
Okay.
As the
MDT
go for
means-
neoadjuvant multidisciplinary team.
Okay. What are the important disciplines comes under this?
General surgery, oncosurgery, radiology, radiotherapy, medical oncology.
So how will you plan this case?
Sir, I will do necessary investigations to confirm my diagnosis and to stage the disease.
Yes.
I will go for true cut biopsy.
True cut. Why not FNSC?
FNAC is not much yielding. True cut biopsy, we can get to know the marker also, ER, PR status, and Herpes status.
Madhu,
Sir.
Madhu,
Sir,
if FNSC done and it showed as a C4 lesion, what does it mean?
FNAC is C4 lesion.
C4 lesion. This is one more point. C1, C2. What is meaning of C1? What is C2? What is C3, C4, C5 on FNSC? Do you know this?
No, sir.
C1 is inadequate sample. C2 is a benign. C3 is a equivocal. C4 is a suspicious. And C5 is a malignant.
Yes.
Okay, proceed. Next investigation. What you want to do?
I will do a mammography and followed by true cut biopsy.
Mammography.
Sonomamography.
Will you do the
What you
mammography?
Will
What
you go?
is-
Do the mammography first, or will you do the needle
I will
biopsy
do the
first?
I will do the mammography first.
So you should have told about that. No,
Yes.
you were telling about the. Or do not say the true cut needle. And true cut is the trade name.
Yes.
What do you call that?
Core needle biopsy.
Yeah,
Core
you
needle
do
biopsy.
core needle biopsy. No? Right.
Yes.
What you will see on mammography?
So mammography, we can see the lesion, mass, any
How it looks?
microcalcification. When it, with
Microcalcification along with speculated mass.
speculated margins.
What are the views of mammography?
Sir, craniocaudal view, mediolateral view.
So how do you identify whether it is a craniocaudal view or it's a mediolateral view?
Sir,
You are giving a mammogram picture. How will you identify that? Which view is that?
Sir, in mediolateral view, we'll see the pectoralis major muscle.
Yes.
We
Yes.
can say that it is a mediolateral.
Right. Okay. Yeah. Okay. Go ahead. Go ahead. So you have done have you done the needle biopsy in this patient?
Yes, sir.
Okay. What is the biopsy report?
Sir, it came out as triple negative.
Hmm?
Triple negative disease.
Triple negative.
Yes, sir.
What were the markers which were done?
ERPR heterogeneous, sir. K67.
Okay. So what was the value of the Ki67?
K67, 30%.
Madhu,
Sir,
if HER2 receptor status is positive, what does it signify? If ERPR receptor positive, what does it signify? And if K167 proliferation index positive, what does it signify? What is significance of doing all these things?
sir, we get to know the
How
type
it
of
clinically correlate?
Sir, ERPR
Prognosis
positive
wise.
cases.
Prognosis wise.
Sir, ERPR positive cases are slow growing tumors, sir. They are good prognosis. They have
Good prognosis.
carry
Very good.
prognosis. Whereas triple negative cases, they have bad prognosis, sir.
And K167 proliferation index, if the index percentage is higher, then the higher progression of the breast malignancy, cancer.
Yes.
This is the interpretation of all this.
Yes.
What is HER2? What is meaning of HER2 positive?
That's it.
It is a breast cancer which is positive for the protein called as a human epidermal growth factor.
Human epidermal growth factor. Yes.
And that promote the growth of the cancer cell.
Yes.
So, how will you test for HER2? One is by immunohistochemistry.
Yes.
Second is a fluorescein in situ hybridization. In immunohistochemistry, we can measure the amount of the HER2 protein. And in fluorescein, we can count out the number of the copies of the HER2 genes. These are the two differentiating points between these two. Keep it in mind. They are important points.
Yes.
Continue.
So what other investigations you have carried out?
Will you go for metastatic workout?
For metastatic workup.
Is it required in this case?
Yes. Yes, sir.
So what are those things?
Sir, CECT, whole abdomen plus pelvis. Thorax, abdomen plus pelvis. I will go for.
Thorax, abdomen, pelvis.
Yes.
Okay. Any other thing?
PET scan. PET CT.
Is the PET CT a standard for the
No, sir.
aesthetic
No,
workup? It is
No,
not. Okay. Now, you have done the LFT in this patient?
Yes, sir. LFT comes out to be normal.
Okay. LFT shows there is a raised alkaline phosphatase is there.
Yes.
What does that mean?
Sir, LFT showing raised alkaline phosphatase, we need to do metastatic workups. And if the patient is symptomatic.
For what? Metastatic workup for what?
For any abdominal mets, liver mets.
For the liver mets and any other mets which can give rise to raised alkaline phosphatase?
Bone.
Bone.
Mets.
Yeah.
Yes.
Bone mets. So biochemically, how will you know that it is because of the bone or it is because of the liver?
Sir, two types alkaline phosphatase. Heat labile, heat stable.
Yes.
It is due to heat labile.
Right.
You can get
So you will look at the subtypes of the alkaline phosphatase.
Yes.
Anything else which can help you? Any other marker, biochemical marker which can help you? You do the calcium of the patient, serum calcium. If that is also raised, then it is likely to be the bony. Bilirubin is raised, it is more likely to be the, or you do the gamma GT in these patients.
Yes.
Okay, the gamma GT is raised is more likely to be the liver metastasis.
Yes.
Okay.
Yes.
Okay. So have you done all these investigations?
So we have done LFT. We have done our routine labs, mammography and through-cut biopsy, core nasal biopsy.
Just
Okay.
show your reports, all reports.
Reports. This is mammography reports. Our core nasal biopsy came across triple negative. The report is, I didn't take the picture.
Okay, next.
Okay, you have to always tell in the mammography of the other breast also, because that can change the treatment plan.
Yes.
Okay, so you have to always tell about the other breast. Okay.
Yes.
So what is the plan now in this patient where there is no metastasis is there? It's a locally advanced breast cancer. So what is the plan of treatment?
I will go with neoadjuvant chemotherapy.
Okay. What neoadjuvant you are going to give? What neoadjuvant you are going to give in this patient who is triple negative?
Taxane-based regimen.
Okay. So only taxane will be given? Which taxane you are going to give?
Carboplatin.
Is that the taxane? Carboplatin? Okay. Either you are going to give the paclitaxel or docetaxel. Yeah, carboplatin, not the taxane.
Yes, sir. Carbotaxel.
Yeah, so you are going to combine the paclitaxel along with the carboplatin.
Carbotaxel.
Why not the CF regime in this patient? You know, classically we are giving the cyclophosphamide, adriamycin, and the fluorouracil. Why not in this patient?
Taxane, triple negative, best respond to taxane based.
Yeah, it is triple negative. Yeah.
Yes.
So they are adriamycin resistant tumor which are there.
Yes.
So you are not giving the CF. Okay. How long you are going to give it?
No.
What is RECIST
Each
criteria?
cycle,
What is RECIST criteria?
RECIST criteria, response evaluation of solid tumors.
Right.
We will
So
assess after 2 cycles, sir, whether the tumor is responding or not.
yeah, at least 2 to 3 cycles have to be given to see for the response.
Yes.
Okay. And then if it is responding, then what you are going to do?
So I will continue the remaining cycles and go for surgery.
What surgery you are planning if you are going to? What surgery you will plan in this patient?
After neoadjuvant chemotherapy, I will go for modified radical mastectomy.
Okay. So after you have done the modified radical mastectomy, what further you are going to do for this patient?
Keep the patient on follow-up.
Only follow-up?
Radiotherapy. Her age is 22 years. Madhu, her age is 22 years.
35, sir.
35. So,
yes.
So after the MRM, what you are going to do?
Adjuvant chemotherapy.
Yes, you have to give the adjuvant chemotherapy. Then radiation. Radiotherapy also to be given.
Yes, sir.
And then finally,
follow.
You are not going to give any further treatment to this patient?
The screening of their family members.
Can you put the patient on the hormonal treatment?
No, sir.
Why?
ERPR negative.
Okay. So can you give on the aromatase inhibitor?
Aromatase inhibitors are not indicated, sir. It is premenopausal.
aromatase inhibitor is for Madhu?
Postmenopausal.
How it acts?
Sir, it blocks the peripheral conversion.
It prevents the peripheral conversion of the estrogen.
Yes.
And how tamoxifen will act?
Selective estrogen receptor modulator.
It blocks the estrogen receptor.
estrogen receptor.
So how will you follow your patient?
I will follow the patient for every 3 months for first 2 years, 6 months for next 3 years, sir, and annually once.
And what are you are going to look in 6 months?
I will get a mammography, then I'll look for the recurrence.
Want to go for implant and flaps?
We can go, sir. We can go for breast conservative. If the tumor size post neoadjuvant, we will assess the tumor size. If it is small, we can go for breast conservative surgery and reconstruction.
Tell me the single screening test, microbiological screening test to do this for the implant or flaps. Microbiological.
No.
I'll give one more scenario. After implantation, there is a breast erythema and discharge from the nipple.
Yes.
And microbiological tests are the positive. Culture. It's positive for culture and sensitivity.
Culture.
So, which is the commonest culprit of all these things?
Staphylococcus.
Which is the commonest organism?
Staphylococcus.
Obviously, Staphylococcus. So, you have to go for the MRSA scan, MRSA screening program.
Yes.
And how will you treat it? MRSA infection?
Linezolid, vancomycin and linezolid.
Broad spectrum antibiotics according to the culture.
Yes.
Flucloxacillin, and wound care.
Yes.
What is trust protocol for the MRSA?
No idea.
If patient is carrier, go and read this. This is also important points related to this flaps and reconstruction. So what are the types of reconstruction?
Level 1, level 2, level 3, oncoplasty, level 4.
Flaps are used. And how will you reconstruct?
Flap, DIP flap, cramp flap, LD flap, LICAP and ICAP flap.
Because this is also one full question for PG. Post mastectomy reconstruction. What are different types of the flaps? Advantage, disadvantage, and vessel involved. Please go all these points. Go through all these points.
Yes.
Madhu,
Sir.
what is the prognosis of this patient and how you decide that prognosis? Hello.
Prognosis is bad. As it is triple negative, it is aggressive tumor. The prognosis will be bad.
Various factors to decide prognosis of this patient.
Tumor grade.
Yes.
Biological markers. Age of the patient.
Tell me all. What are good prognostic factors? What are bad prognostic
Madhu.
factors?
Sir.
Suppose you did the mastectomy and you are given the sample for the pathology reports. So what to look in this sample? Basic, simple question. You did the mastectomy, you send the sample for the pathology. So what to look for this? Or what to report?
Whether there is malignancy or not. Whether the tumor borders
Type of cancer.
type of cancer.
Then number of positive lymph nodes.
Yes, sir. Number of lymph nodes.
Marginal
Whether
status. Whether
margin
margins
status,
are free or not.
lympho
Then HER2
transfer
receptor status. ERPR status.
grade of
Then
tumor.
Ki-67 proliferation index.
Dr. Kanagal, can you finish now?
I think we can now wind up.
Yeah, we
I
can wind
think
up.
if he has any questions, we can ask, sir. Otherwise, Dr. Madhu, do you have any doubts to be clarified?
No, sir.
Thank you very much. Any other faculty would like to give any comments? So with the permission of the faculty, we call it a close. We'll meet next Friday. Good night, everyone.
Thank you, sir, for
You do
giving
nice
some
presentation. Good night, sir.
Thank you, sir. Thank you,
Thank you,
Professor Mote, sir, for staying all through.
Thank you, sir, for
Good night,
opportunity.
sir.
Thank you. Thank you.
We had a nice time.
Yes, sir. And friends, we have 2 cases for next week. Short case will be a soft tissue tumor. Long case will be an obstructive jaundice from AIMS Bhopal. Short case will be from Hyderabad. Thank you very much.
Okay. Thank you, sir. Good
Thank you,
night.
sir. Good night, sir.
Good night.
Good night, sir.